conjunction with the other reports that we've taken through the ICB board, there will be some substantial changes to the work that we're doing in neighbourhoods, in places, and at West Yorkshire, and they will be very rapid. The voluntary redundancy scheme for West Yorkshire ICB staff we want to open on the 26th of November, and we want to get a very quick response from people about their intentions or their commitment to wanting to go for that scheme. We need to try and make progress on our formal consultation, and we want to do that in January, and we want to make sure that people start to leave the organisation before the end of this financial year in substantial and significant numbers. So that will mean that as an integrated care board, we are prioritising our work. It's the priority areas that we want to work on, the core work that we have to do, and we will also be working closely with partners around what the consequences might be for them. All the providers in the room are working in all of the places to make sure that we've got arrangements for good integrated care with integrated leadership. And at this level, the last thing I'll say is we need to decide what kind of partnership we want to replace the partnership we have currently and the governance around that in the context of strategic authorities and the combined mayoral authority, and in the context of this not being required to be statutory anymore. We previously came together as a partnership board when we had a voluntary partnership, if you like, because we thought it was good to govern the things that we needed to govern together, because there are some times when you need to do things at West Yorkshire level. And there's a piece of work going on with combined authority colleagues and ourselves to try and put some options together for that. But this partnership will have to decide as a group of partners how it wants to be governed in the future. Thanks, Tim.
Thanks very much, Rob. Nadia, I don't know if there's anything from your report to the ICB you wanted to add anything about?
I think Rob's covered most things, but in previous meetings, I think partners have showed some concern about how we're going to make sure that we continue to hear the public and patient voice at the ICB. And I just want to reassure people that we are working on this. We have a named non-executive officer whose role this is, but also we will have a named person in our executive team whose responsibility it will be to gather and coordinate these voices. And we have a wonderful relationship with our voluntary sector, some members sitting here who are supporting us in this as well. Thank you.
Thank you. So can I open this up for any questions and comments? Yes, Sylvia, Councillor Dacre.
Yes, thank you, Chair. I'm Councillor Sylvia Dacre from Calderdale, and in your report you said that you were waiting to hear as to whether your preferred redundancy consultation would be able to start on the date you'd asked. Now, I assume from the way you worded it that you haven't heard anything still.
We haven't had a formal response, but all the indications are that we'll go with the timetable that we've set out in our correspondence with NHS England. So that would be start the voluntary redundancy scheme next week with indicative structures made available to people so they can get a sense of whether that might be a good thing for them to do or not, and then have the formal consultation start in January. So that's the intention. We haven't had the formal response back yet, but I'm sure it will come shortly.
Thank you. Any other comments? I think just perhaps say from local council, local authority perspective, that thinking about the future of the partnership board and partnership arrangements, I suppose two things really. One is that obviously the government is placing a lot of increased emphasis on the role of combined authority on mayors within that, and that's fine, and clearly there are important links at that level, but I think we'd probably want to emphasise that there are very significant responsibilities and contributions that will remain sitting with local government, and we need to make sure that that council voice is part of the partnership arrangements as well. And linked to that, I think because we developed our partnership arrangements in West Yorkshire before the legislation, I think the national legislation makes a clear distinction between the ICB and the Partnership Board, which doesn't reflect the reality of how we operate. The reality has been that all organisations are embedded at all sorts of levels, and that's the strength. And again, I think that's something we would very much hope to see continue, although recognising that the servicing and support of those partnerships is going to be very different with the ICB reduced. Councillor Hinchcliffe.
Excellent. So yes, thank you very much, Councillor Swift, for that. I think we have said before that in West Yorkshire we are going to include a council representative on that board. We've always done things quite well in West Yorkshire and have been seen as a place that others follow, and I think we should again set an example in this instance. So I think that's what we all think should happen, as well as the mayor, obviously, for the wider determinants of health. It's by having a partnership approach that things really work.
Thank you. And I think that's been a consistent theme of the discussions we've had, hasn't it? Any more questions or comments? Sorry, Catherine, yes.
Hello everybody, Fatima Khan Shah, West Yorkshire Inclusivity Champion, which is a role shared between the Combined Authority and the Integrated Care Board. It would be remiss of me, Chair, not to, in light of the changes that you've described and what's mentioned within the Chief Exec and Chair's report, to remind the Partnership Board of the importance of embedding and consolidating the work we've done on equity and fairness. I mean, Rob's report really highlights some of the challenging waters that we're heading into, some of the challenging waters that women like me are already experiencing. And quite often what we see during structural and organisational changes is that those inequalities are exacerbated. So I suppose what I'm asking for, Chair, and it's a bit cheeky, but I wouldn't be me if I didn't ask for it, is for individual partnership board members to consider those implications, not just within their organisations, but in the forthcoming place-based and integrated neighbourhood arrangements. One, sort of building on the work we've done so far in equity and fairness, but also more importantly, how we can take things further, because that is how we roll in West Yorkshire.
Thanks. Rob, you want to?
Just to thank Councillor Hinchcliffe for raising the point. It's critically important to us that if we think about places and the way that we work on the principle of subsidiarity, we want to do as much as possible to as close to the person as possible. The national policy around integrated neighbourhood health services is a positive one. Slightly misnomer, I think, isn't it? Because we would say it goes beyond the NHS into the broader and wider determinants of health and represents all the partners in the room, including the person themselves. So having that neighbourhood health arrangement in places where people live, thinking about that in the broader local authority footprints of Leeds, Calderdale, Kirklees, Wakefield, Bradford District and Craven, you know that you're going to have to do a lot of the work in the places. So the providers in the room working together in the place with local government, the VCSE, is where most of the work should be managed and coordinated, with less of the ICB in that space, I would say, and more of a focus on local partners delivering in a way which is going to make the biggest difference possible to outcomes. So that puts quite a lot of onus on the other partners. And what we've tried to do in our approach to this is to create some capacity to help facilitate that, but that will transfer into those arrangements rather than be with us. So we want to help to get that right, and we want to make sure that we continue to have that really good political, managerial, clinical and citizen leadership in those local authority footprints. And that's something that's part of our system development, organisational development programme. Plus, I should say, that just before I forget, that health and wellbeing boards have to sign off those neighbourhood health plans too. So all of the health and wellbeing board chairs and partners here will have a voice in that, which I think is a really good thing.
Thanks. I think that's kind of true of our values across the board, isn't it? We've spent 7 years developing a way of working in West Yorkshire which values system leadership, shared ownership of our issues, a strong focus on equalities, And the challenge now is to make sure that those behaviours are continued and modelled by all of us if there's less of a central focus and direction possible through the ICB. Okay, any more questions or comments for Rob? Okay, in that case, I'll move us on then. Thank you, Rob, to the first of our ambitions item and invite Keir to introduce this. Thank you, Keir.
Thanks, Chair. So my name's Keir. I work on behalf of our collaborative of NHS Mental Health Trusts and West Yorkshire ICB. So thanks to my colleague Emma, who's our consultant in public health, who's helped pull this report together. So we were asked to update on that one of our big ambitions, which is about reducing the gap in life expectancy for people with severe mental illness and the rest of the population, and for those with learning disabilities and autism as well. What we're focusing on this paper in particular is, rather than doing a broad update on the totality of that ambition, because we did that last time, is to focus on a particular area. So actually, by taking the theme that if we provide the right interventions in childhood, we've got a real opportunity to prevent and break that cycle of future inequalities, in particular in relation to mental health. One of the reasons why we thought that was appropriate to focus on at the minute is Health Watch shared some insight, particularly around concerns relating to children's mental health and the advent of what we've got at the minute in terms of the digital world and the digital space. So I'll do a bit of a kind of a summary of what some of that insight has said and some of the direct quotes from young people that Health Watch have found as well. So some of the feedback that we got from young people includes things like recognising that an awful lot of young people often get their health advice direct. At the minute, they get it directly from the online realm, so from internet searches, social media, and things like ChatGPT. It's often a place where people go to get that advice and support. But we have to recognise that different individuals, different people, different communities prefer different methods of engagement. So whether that be the online sphere, whether it be still a reliance on really good, high-quality face-to-face interactions as well, it's not like every young person is relying upon kind of in the digital world. We do hear through our Night Owls service, which is the online, it's the 24/7 helpline for young people across West Yorkshire, that they want a combination of support. They want online interaction, they want the ability to text the service, they want the ability to speak to people, and that we know as well, essentially with all of these services, what we want to make sure we provide is variation in flexibility in what we are able to offer people. So some of the direct quotes from young people, and this kind of represents views across the spectrum, are things like, well, AI, so things like ChatGPT tend to feel like it offers personalised care. It feels like it kind of understands me as a person. You can factor in unique aspects of people's needs and backgrounds. They're getting that sense of that relationship with AI. Other young people saying, well, actually, it'd be really, really great if there was a training resource or information about how to support us to judge that information. How do we trust the information we get online? And what are the pros and cons of getting any of our support in these sorts of realms? And then all the way to the other end of the spectrum still, which is young people still really saying, well, I feel like talking to people you know in person works better. So there's still that real combination across the board, and sometimes it's about accessibility, sometimes it's about the feel that young people get with the support that they need. So what the paper tries to describe essentially is how digital technologies interact with well-being for children and young people, so particularly things like social media, but also recognising the role that healthcare plays and healthcare interaction in terms of the digital world. So what are the opportunities for artificial intelligence as we go forward? How can we make better use of digital apps, digital diagnostic tools, so we're not always having to do things in a more analogue way, which fits in with the 10-year plan, obviously from NHS England. Some of the specific opportunities that we've got in relation to children and young people. So the existence of the online sphere for mental health really can help with accessibility. It will help with access. It allows people to get hold of services that they might otherwise not be able to do, but there can be huge risks with that as well, that it can be really, really hard to validate the quality of those services that people get access to. And we recognise as well, when we're thinking about inequalities, the marginalisation of those who cannot access that stuff when other people can. So if we're really focused on our 10 ambition being about narrowing that gap in inequalities across the patch, the fact that digital offers exist and are accessible to some doesn't mean that they're accessible to everyone, and there's a danger of widening that gap. And then we've got other issues around kind of data security and all the stuff that comes with the digital sphere too. So some of the main concerns that have come up in relation to children and young people, the digital world and their mental health. Some is about how do we reduce the harm to young people about overusing digital and living in that sphere. So some of this, from a kind of thinking of it from a real public health lens, is the danger of increased sedentary behaviours. You know, people are spending more time at home behind a computer, however socially interacting it may well be. Chances are they're not out and walking around. Some really kind of basic things that can be a problem for young people. There is the flip side of the fact that for some young people it really helps enhance their ability to interact with their peers, and they can do so at all hours of the day. For others it leads to a sense of social isolation because they can never escape it, and therefore they want to kind of hide from it. And then there's a real kind of danger as well about the increasing dependency some young people have with these sorts of technologies. And of course, again, thinking about the quality side, how do we able to mitigate the risk of some of the harmful content that people can access? We know that there are a range of public health strategies that are needed to mitigate some of these risks. Some of those are national. So the fact we've got regulation and laws needed that will help with kind of age restrictions, etc. There's some things that are not within our direct gift in West Yorkshire. But there's an awful lot that we can do locally as well. So more through our schools, potentially, around awareness campaigns, promotion of alternatives, trying to enhance the digital literacy of the population as well is really important in this, so that parents and families feel empowered to support their young people. From our mental health support services themselves, making sure that over time we are growing the number of services who are there to help with those young people who are experiencing harm as a result of the online world, and as well as making sure that our mental health service provision itself has that blend of digital, online interactive offers, but also the ability to make sure we've stepped up and have got the face-to-face interaction that we still need for young people as well. Then if we look at the kind of the positives that exist, so there's a real opportunity to use digital from a children and people's mental health point of view. In terms of primary prevention, if we can get access to good online information and make sure that social media is used in the right way as a force for promotion of reputable public health strategies, there's real opportunities there. The fact that we've got text and online chat functionality, online groups for children, for families, helps us build some of that community and can help with the secondary and tertiary prevention agenda. And then if we look at treatment and recovery, we already have across West Yorkshire in pockets some really good access to really good technologies, some of which things like Luminova, My Happy Mind and Couth are really good examples of technology that we do use. Again, in pockets. We don't use it everywhere, and there's real opportunities to make sure that how do we know that they are the right things for our population, and how do we ensure, coming back to the inequalities point, that if we think they're the right things, that everybody can get access to them across the entirety of the system. So essentially, there's real opportunities for digital approaches to be embedded, but we need to focus on the equity bit. So it feels like we need to make sure that any work on digital literacy, education and support is targeted at those families who are going to most benefit. So digital services need to be supplemented by face-to-face access for those experiencing digital poverty. And as well as the kind of almost the commissioning intention behind this as well, we need to make sure that all of our providers of care move at a similar pace. So particularly in the AI sphere at the minute, there's always a bit of a danger that separate providers might be able to progress some really whizzy new initiatives faster than others, which can be good, but not if we want to narrow the gap in inequality. So we need to make sure that learning from those organisations who are moving quickly is shared across the rest of the patch. So, yeah, ultimately, in trying to reflect on what we think we needed from a thinking of the future and the ICB as a strategic commissioner, thinking of how we consider the impact of digital on children's mental health within neighbourhood plans and the role of all the partners in this group, there are probably a few things we thought really need to be a focus really. So one is, how do we collectively understand more about those digital offers, how they can best be used, and how they're part of a system-wide strategy, which is about rollout and adoption of those digital technologies. That focus on ensuring equity of offers across all places and providers. And finally, making sure that we've got the right collective capacity. So how do we make sure we've got capacity in teams to roll out digital in the best possible way, but also coming back to that digital literacy point, how do we make sure we've got the right understanding and capacity in all of our clinical, operational, social teams to help children and young people know what's out there and know what is needed to support them really. So bits for the ICB, bits for wider partners, but some real opportunities to make sure that we almost take advantage of the fact that there's a real opportunity within digital mental health for children and young people that can help in narrowing that inequalities gap. So that's the summary, Chair.
Thanks very much for that introduction. Shaukat, I was going to see if you wanted to comment from your role.
Yeah. Thank you so much. My name is Shaukat Ali Khan. I'm the CDIO for the West Yorkshire ICB. I think it's a really good report, and I'm really glad. I think the positive part is that West Yorkshire ICB, we have done a lot of work in this part, and then we have just launched a West Yorkshire Digital Data Technology and AI Literacy Program, which has these components. If you can just give me 1 minute, I will just quickly go through on what this is. I think just to be relevant on what was said in your report, and I fully agree with that. So we have launched a digital data technology AI literacy program, which has 5 verticals. The first vertical is digital literacy, which includes, of course, all the 100,000, which Rob just mentioned, 100,000 colleagues in the health and social care, but at the same time, all the citizens, and then all the children, especially. We have a young ambassadors program, which is targeted towards the education, digital awareness, cybersecurity for the young kids, and that the overall planning is to work with schools and university and academia to bring that awareness, and then use those young ambassadors to actually spread our voice to the other communities. The other one is, of course, the citizens. All our 2.7 million citizens, we need to also inform what are the digital tools available for them to connect towards NHS services, and then is how to deal with that. And then we have other ones like a distinguished lecture series where we are bringing inspiring leaders from around the world, within UK, outside UK, bring to our West Yorkshire to inspire us on the digital part. And then we have special programs for leadership, like board, partnership board, and our ICB board on digital literacy on a board level, and dedicated programs on AI and cybersecurity. So I think the important part here is that we have actually done a lot of work in bringing this program together, and we have launched that. So I will be very happy to work with you, Kier, and then see how we can leverage our expertise together, and then leverage on what we have and then what you have found out. And then I think with this, I also want to inform all the members here that we have this program. So if you think that something is interesting in your part, we'll be happy to come and then have a detailed discussion with yourself. And based on this program, there's a lot of interest from national and then regional. We have already seen who are contacting us, and we are sharing with them as well. Thank you.
Thank you. That's helpful and valuable context. So, questions or comments? Yes, can I come to you first?
Hi, thank you. Helen Rushworth, Healthwatch Bradford and District, representing Healthwatches across West Yorkshire. Thank you so much for sharing that paper and acknowledging our role in supporting it. I think it is fair to say that the information that we got from children and young people was incredibly uniform across all the patches, that they were looking at digital as very much a way to receive that intervention, I guess, in their mental health journey. What remains a significant concern for us as health watchers is the vast numbers of children and young people who are waiting years and years for appointments, for diagnosis and for support. And whilst I hear loud and clear that you're looking at internet safety around a digital policy, I think we also it'd be very remiss of us not to acknowledge that whilst those children and young people are floating around without any support, they are hitting the internet, and they are seeing things like anorexia support groups. They are seeing things like suicide groups, how to do it. So that remains a huge concern, and I think as a partnership, we need to have that very much at the forefront of our minds.
Thanks very much. Perhaps I can just add before I bring Jen in, because you touched on something I was going to raise there in terms of the assessments. I wondered, the report doesn't talk about whether there's any potential role of AI in helping with that whole process of assessment and access to services, and I don't know whether that's something anybody wants to comment on. I'm interested in what you say about the message being there, because the feedback I got from some Calderdale colleagues was that it was quite mixed, that yes, young people are using internet to access things, but actually there's still a strong valuing of personal and peer support as well within that process. So it's a complicated message perhaps about where they're going. Jen, shall I come to you next? No. Bring you back in, Keir. I want to take 2 or 3 more people.
Thank you. Jen Connolly, Associate Director for Improving Population Health, working jointly between West Yorkshire Integrated Care Board and West Yorkshire Combined Authority. I just wanted to mention the work that the Healthy Working Life programme is doing, which is looking at improving employment outcomes for people with long-term conditions that can include mental health conditions. And part of that programme is in particular looking at how we use some digital therapeutics to support people from becoming, to help them with their kind of staying in work and avoiding them falling out of work due to their ill health. That's being really well evaluated, and we're one of 3 sites doing that kind of accelerator learning at the moment. So I think there'll be some important learning on those particular digital therapeutics, which are going through the kind of I can't remember what the DTAC acronym stands for, but the appropriate quality processes. So there'll be some really good learning there, and some of that, whilst it's not exclusively for use by children and young people, some of that will focus on a younger adult population as well. So I think there'll be some good learning for the wider the wider work that you've referenced. And just to draw that link again, but with the importance of supporting people with their digital journey and their mental health journey, and the 2 are linked for the challenge that we're seeing in terms of increasing numbers of children not becoming economically active in the way we'd all want them to be. So I think there's another link to draw with the programme there as well, so we can maybe have a follow-up conversation. Thanks.
Thank you. Fatima?
So just in response to particularly the question about the role of partners, areas that I particularly focus on as the inclusivity champion is digital inclusion. So we work collaboratively with local government leads across the sort of 5 boroughs of West Yorkshire, really making sure that the services that we're providing has the infrastructure for people to access them. So one of the things that I'm particularly keen that we work with partners to ensure we consider is digital poverty, and that people have the opportunity to not only access, but the money to pay for internet access to ensure that they continue to access it. There's also a lot of work taking place on the bias within artificial intelligence. So we know that AI, for example, can be biased towards, for example, gender, ethnicity and sexuality, etc. And it's about how we can work collaboratively with those partners to ensure that people are aware that when they're sourcing information to make sure it's accurate. And then the final thing is we've just signed a memorandum of understanding with an organisation called Good Things, which has also done some great work in the artificial intelligence space as well. So I think there's some areas where we can collaborate on, Keir. And although the Mayor's on her way, I think it would be remiss of us to not mention the Child First approach that the Combined Authority have also adopted, and maybe some learning that we can collaborate on in there too. So maybe some actions for us to take outside the room, Chair.
Thank you, Fatima. Helen?
Thank you, Chair. Helen Hurst, Chair at Coldwell and Huddersfield Foundation Trust. I know while the paper is essentially around children and young people, and we're talking about inequality gaps and around sort of digital literacy gaps, I think there's also, for me, something about a parent, adult, child gap, personally experienced, where there's a growing divide, I think, between what how children and young people access information, how their parents do, how their wider families do, and a real ignorance, I think, around what is and isn't available. And I know a lot of schools are now getting much, bringing parents much more into the conversation around sort of digital safety and the like. So I wouldn't like us in a focus just around children and young people to lose the sort of wider family units within which they live, and sort of thinking about that sort of broader. And I know the same arguments apply about digital literacy, about inequality, but I think we shouldn't focus entirely on the children and young people without thinking about the families in which they live.
Thank you. Mark, I wasn't sure whether from a provider point of view you wanted to make any comments.
Sorry, apologies, sir. Yeah, I mean, as a provider of CAM services and for other young people's services, I think what Kia's raised is absolutely vital, and I actually agree with what Helen's just said about in terms of recognising there are differences between how people access information today compared to 10 years ago, 20 years ago, 30 years ago, etc. We're certainly seeing, I think, a significant increase in the number of referrals for CAM services since the pandemic, and it's a different type of demand as well, I think, from what we've seen historically. It's certainly more complex, and so I think some of the issues that have been raised about WhatsApp groups, internet groups, etc. So I think it's actually upon all of us to be really, really clear in terms of what the benefits are of digital, and as Fatima said, the inclusion element's really key, because actually we know that not every single community, not everybody in every community can actually afford the access, whether it be to the internet or to digital means. So I absolutely support the paper, and the comments that have been said have actually been really articulate and provided a lot of insight as well.
Thank you. Susan?
Yeah, I think it's a scary old world, isn't it, all this digital stuff, to be quite honest, because it's unregulated. People are taking advice from people who are not qualified to give advice, and actually it's advice that might make them worse, just going with what Helen says. I think it just emphasises the point that really, when it comes to children's mental health, and in fact adults as well, but obviously I'm particularly focused on children at the moment, is how we get them support that they need quickly, because if they don't get it quickly, they will go looking for other sources of help that are not appropriate and might make things worse. So I think this paper needs to be seen in the context of the support we give to young people straight away, really. We can't leave them waiting for things. If we leave them waiting for things, they're going to go and access something that's not appropriate. So I think this is probably relevant for a lot of the things we deal with in a health point of view, isn't it, really? And therefore, we need to be mindful that people are needing things speedily now. And if we can't provide it speedily, they're going to look for other alternative methods, and that's not positive.
Thank you. Kim.
Thank you, Chair. Hi, I'm Kim Shuttler. I'm the VCSE lead on West Yorkshire ICB, but to declare I'm also the Chief Exec of a mental health provider. My point was sort of building on Helen and Susan's, actually, that people might have noticed that it is unlikely that there'll be a mental health investment standard in the NHS budget going forward, and I'm really proud that in West Yorkshire we've had a strong commitment to mental health and do some fantastic work. I suppose the reason why we have a mental health investment standard is to have a minimum level of investment, which doesn't even come close to allowing us to have parity of esteem with physical health. So I hope that as a West Yorkshire partnership, that we will, regardless of the mental health investment standard that is agreed nationally, continue to maintain our commitment to investment in mental health to address some of these gaps.
Thanks very much, Kim. Important point. Vicky.
Yeah, it's just to pick up on a couple of points from people. So within Kirklees, I'm the interim accountable officer for Kirklees. We've done a lot of work on children and young people, mental health specifically. We do use we commission My Happy Minds as one of our tools that are used as part of it. I think one of the key things for us has been how you quality assure. So there's lots of different tools out there, and I think as Kia's paper has alluded to, depending where those providers target, whether it's GPs, whether it's providers, whether it's local authority, they can get a different response to what they implement. So for us, it's been about how we've quality assured the providers that we've used, and then how that has been integrated into our pathways. So that's been a crucial element for us to be able to do it. The other bit that I would say in all of this as well is it's part of the education element of this. So I think, as was said, Helen said, about taking the families along and making sure that the parents are fully involved. But one of the key things for us has been people recognising this is part of the treatment, intervention and pathway. It's not as well as. In some cases it is as well as, because you're moving along a continuum. For some people that is the right intervention. So it's about targeting it at the right place. But getting people to recognise that, because sometimes they see that the digital area is so accessible. It's not being commissioned as I'm going to say a health intervention. So trying to say to people, we have quality assured it, we've worked with, we've done impact assessments. When we've done our procurement, we've made sure that we've ticked various boxes to say it meets NICE guidance, it meets the must-dos and the trajectories that we've got to deliver, all those sorts of things. But it is an intervention, and it is commissioned on behalf of the health system or the collective system. So that's something that I think we've got to keep working on as well.
Thanks. That's a really interesting point, because I've heard some conversations around Couth, for example, where people have talked about it in that terms as it's something young people can use whilst they're waiting for proper treatment rather than part of it. Sorry?
It is the treatment.
Yeah. Yes, sorry. Yeah.
Hi, yeah, Sally from the Youth Work Unit for Yorkshire and Humber here is representing the VCSE sector, who is supporting youth work and young people across the region. I suppose mine is just looking for a little bit of clarity. I understand from Helen that Health Watch young people are saying that they're turning to digital because they don't know where else to turn to. Do we know that they want everything on digital, or is it that they want digital to access in person? And how easy actually is it to find in-person support for the region? So do they know where to find? Is there an obvious place where they can go find who they can talk to there and then? Because that's the prevention, is getting to the point where they're not into the referral systems, is where they're just genuinely getting some face-to-face help. And actually, how do we know that from young people? What is it they actually want that digital to do?
Thanks, that's a good point. Helen, do you want to come back on that at all?
Yeah, to the best of my ability, as I say, I represent Bradford, and that report was brought together from Health Watches across the district. My understanding of it is that the children and young people who are referred to in the report, that were part of that, were looking at digital as their primary support. So it wasn't necessarily whilst they were waiting, or necessarily entirely instead of the face-to-face support, but that was where they felt comfortable, and there was something very much around, and it's what Helen was saying, and I think is a concern, another concern, that they can access that on their own, and it's that kind of confidentiality and that privacy, which from a parent perspective raises red flags, doesn't it? You know, who are your children talking to? Do you want to be part of that? As a parent, I would want to be part of that counselling process or whatever was going on. So there's definite pros, but I think there's cons as a partnership board, those that I raised earlier, and then some other ones as well. But yeah, children, young people they love it. You know, they want to get onto their iPads, they want to be on the phone and be able to access things. Now we live in an instant world, don't we, for children and young people? They don't want to be waiting, weeks, months, years for appointments. But it isn't just that instead of an appointment, that's how they would like their care to be delivered.
Just saying, none of us want to wait months on end for appointments, so we can appreciate that. But yeah, no, it was just interesting to hear how they wanted to use digital in respect. Is that the only thing, or is that what they're having to turn to because they don't feel they can go anywhere else? Brilliant.
Thank you. Yeah, Rob, do you want to come in?
Yeah, thank you. I think it's a really good conversation. I really welcome the perspectives around seeing the children in the family and seeing the family in the context of their environment as well. One of the things I always remind myself is that mental health spectrum, and we're going from emotional well-being through to people with severe and enduring mental illness. And you're not going to be supported with severe and enduring mental illness through digital means exclusively. So there may be times when there is no choice. We've got beds for children who are really unwell in West Yorkshire, haven't we, for example? So in this context, I think we should always see that whole spectrum. And that for me starts with, do people have a healthy home that's warm? Do they go to school? And if they go to school, does the school provide good well-being support before people become unwell? Because that's the primary prevention. And if people are becoming mentally unwell, then they need some mental health interventions. Sometimes I think we can appear to be straying into it's all about the CAMS service. It's not all about the CAMS service. It's about that whole spectrum. And the great thing about the partnership, I think, with our focus on children as a priority is we try and take that perspective. And we've got the people in the room who can take that perspective. within that, I think what we're saying, and there's a really nice bit in the paper which asks us to do 4 things, I think, which we might want to come back to. You know, do we think we've got a coherent offer that's evidence-based? Are we committed to that? Are we going to make sure that we fund that? Do we recognise there's a kind of rising tide required to get access? The government's own targets around children and young people's mental health haven't yet been to cover the whole population with fast access. There's been a significant improvement, but it's nowhere near where it needs to be in terms of keeping up with demand. So it seems to me that if we come back to what this paper is saying around the role of digital, having quality assured tools which are part of a whole package of care and some preventive measures, then we'll be in the right space as a partnership. But there's definite continued action that's going to be required if we're going to get anywhere close to providing the sort of services that people want. The other thing I always remind myself as well is that I grew up when there wasn't an internet. And no, it's true though, isn't it? You know, if we think about it for a moment, we've experienced life before all of that. This generation hasn't. So their reality is just different from ours now. Perspective, we're wired differently. And we need to take account of that, and we need to make sure that we're listening to their voices in all that we do.
Thanks very much, Rob, and just for bringing Keir back in, and I appreciate there's a lot to respond to already, and the 4 things. I suppose for me the slight elephant in the room is that question about how far what we feel about young people's access to social media and the internet generally, and clearly that's quite a controversial area nationally. There are people, or internationally, you know, there are people who are arguing that too early access to social media is itself a cause of mental health crisis in young people, and there is a debate about schools. Now, clearly, we can't directly control that, but perhaps there are some questions for our public health colleagues about the kind of advice and messaging and what the good evidence is again on that, because clearly if we're taking the line of saying that you know, digital is going to be an important part of our offer for mental health support for young people, then that implies that young people have that access and has other implications. So I think it's something there. I think the paper has been really valuable and the discussion around it has been really valuable, but I think it probably has prompted some more questions and some more work for you, Keir, with respect. But I don't know if there's anything you want to pick up and respond to on this.
Thank you. Yeah, it's just a couple of the points that were raised in the discussion. So 3 bits. One was on the AI, one's on the wider diagnosis challenge, particularly I think around neurodiversity, and then one's around, and Rob touched on it, I think that interface almost between severe mental illness and well-being and prevention. So on the AI bit, so it's fair to say all of our providers are looking at the role for artificial intelligence in trying to support some of the diagnostic pathway, and from an ICB point of view, providing some funding into that. I think there comes back to some of that danger. So it's how to phrase this, I suppose, but we get an awful lot of emails from kind of that said, here's a solution. Here's an AI solution that might be able to help a provider with their kind of in the waiting list or in providing support to young people. To Vicky's point from before, it's about the quality and the validation of some of that stuff, and I think what we're trying to make sure that with our providers, they are sure that any application of artificial intelligence is safe and supportive and going to do the right thing. So there's that point. In terms of wider diagnosis, and particularly around neurodiversity, so it's fair to say we are trying to make sure that from a West Yorkshire perspective, we are increasing the commissioned capacity that does exist across the system, but it's commissioned capacity that meets the quality standards we expect from those providers, so that people who are getting a diagnosis are definitely getting the right diagnosis, and they are able then to access the right follow-up support, whether that be medication or kind of further pathways. And we are really clear that in the medium to long term, what we do want is to make sure that in our communities we have the right neurodevelopmental support, regardless of whether people are waiting for a diagnosis, have had a diagnosis, or have needs that need to be met, but they may not meet the spectrum for an autism diagnosis or an ADHD diagnosis, but they are struggling with something that requires some needs. But that does mean it's a change. It's a change in focus of what we commission and what that looks like. And the final thing, which is about that interface bit, so within the government's ambition, it is the ambition to roll out mental health support teams to 100% coverage of all schools and all of the population. So from a West Yorkshire point of view, we've got a lot of mental health support teams in our schools already. They kind of are that interface bit, so they work with the schools and the interface with the local CAMHS provision as part of that kind of early intervention, prevention end, but we don't have full rollout everywhere. But as Rob was emphasising, that's not CAM's provision, that's the interface bit that does a bit of support that can help young people at an earlier point. And ideally, if they work well and that coverage works well, should free up some of the capacity at both ends, particularly free up some of the capacity within the specialist CAM's end to focus on those who really, really need it. But yeah, we are on a journey to kind of full coverage with that, as is the rest of the country.
Thanks, Keir. So perhaps just remind people then that the 4 areas that are highlighted in the report are there to see. So it's particularly about coherence of the offer, which doesn't necessarily mean everyone providing the same thing, but providing to the same standards and in a coordinated way. The equity of access point, I think Fatima made some really important points about the work that's going on to secure that. The understanding about the very different roles, I think that some of that overlaps with the point Rob was making, that what's appropriate for prevention and early stages is not necessarily appropriate for profound mental health, and a coherence of the offer and understanding of how it progresses and develops. I think there's probably general agreement about those, but I think the debate's also demonstrated that there is quite a lot of further work and discussion that we want to see happening together. Is that a fair summary? Is there anything else anybody wants to add? Vicky, yeah.
Yeah, it's just one point, and I think it plays on what Keir's just said about the mental health support teams in schools. One of the things that's allowed Kirklees to progress quite rapidly at pace on this is that by doing the quality assurance of My Happy Minds, for example, we've taken the schools along with us, and actually we've got to a point where we've agreed to joint fund. So it hasn't been all health funding. We did the testing and the piloting of it. We did the quality assurance, but that evidence base, the schools have come on board with us. So we've now, or we will have by the end of this year, 100% coverage of My Happy Minds across all our primary schools. But that's because the schools have agreed to joint fund with health, recognising we all get a benefit of delivering this. It's not just that top end of services. So I think there's something in this about how we collectively carry on working in partnership and collaboratively to do this. We've only got the pound to spend once.
Thank you. That's a useful example as well. Rob?
Yeah, thanks, Chair. I thought there were a really helpful summary and really good conversation, and something which is very live in all of our organisations as an issue, and where we get a lot of feedback. We heard 2 things, I think, in the conversation which weren't in the paper, which we might want a position on, or we might ask the question for somebody to come back with a position on. So the first was around the mental health investment standard. And for those who don't know what that is, it says that effectively, if the NHS gets growth of X%, then mental health should get X% plus a little bit as a minimum. So you're making sure that you're always investing slightly more than on everything else in mental health services, just to catch up and get some parity of esteem in there. We don't know whether that's going to continue. The allocations are coming out imminently from NHS England. Irrespective of whether it continues or not, we know that mental health morbidity is increasing significantly. So Mark was telling me earlier about the growth in referrals with 500 and... Give us the number.
For ADHD services between 2019 and 2024, we had a 565% increase in demand for referrals.
So we've got a sort of exponential increase, and we need to, if we're a true strategic commissioner and a true partnership, then we need to look at a strategy that's built from the health needs assessment of local population. And my view would be, as a strategic commissioner, you need to invest in the things that are going to make the biggest difference as far as you can. So in principle, I think in the strategy we should have differential increases in mental health services continuing. So people might want to mull that over, but when we're signing the strategy off, I think that might be one of the things that we end up saying, as well as community services, primary care as part of the whole left shift agenda. So unless anyone vehemently disagrees with that, that's probably what we'll come back with. I think the second's much more contentious probably. It's the point you raised, Chair, about social media in schools and access to social media. And it's whether you do want the public health professionals in the partnership to come back with a view that we could consider that you might want to recommend to others.
Yes, of course. Nadra.
Yeah, thank you, Chair. I don't think I introduced myself earlier on. Nadra Mirza, Acting Chair of West Yorkshire ICB. It's been a really interesting conversation, and Keir, thank you so much for preparing or having this paper prepared here. I think something that I feel is missing is the fact that the way we're looking at mental health, the process from diagnosis right up to services, etc., appears very homogeneous. And really our communities are so incredibly diverse. So I think at each step we have to consider things like cultural background and faith and non-faith, etc., alongside the context of family or no family, etc. So I think it becomes a much, much bigger paper and a bigger service, really, when we start adding all those differences. But I think as practitioners and decision makers and leaders, we've really got to be cognizant of that diversity when we're working with people from pre-diagnosis right up to accessing services, because we know that for some of our communities we don't have appropriate services, we don't have a diversity of access points, etc. Just a reminder to us. Thank you.
Thank you. Thank you. So the 2 points Rob raised, I think I saw signs of general assent on the first one about the mental health standard, that at least we would want to see that point considered and addressed as part of the strategic work going forward. On the second one, certainly personally I would welcome some work, and whilst I appreciate at the very least at the level of looking at the available evidence and recommending what good practice looks like, and whilst that could be done at an individual authority level, it would seem sensible perhaps to ask public health colleagues to look at that collectively across West Yorkshire, if that was okay. And that might be something we want to bring back as a separate item on a future meeting. Mark, yeah.
Thanks. So sorry, I think it's appropriate. I'm obviously not going to disagree with Rob wanting to return investment in mental health services. I think it's just worth pointing out, I think there's been some fantastic outcomes from having the mental health investment standard, such as individual place department teams putting people back into employment, talking therapies expansion, introduction of increased expansion of perinatal services, children and younger people services. Where we do have a real challenge is in people with a severe mental illness, where there's been a lack of investment in recent years because of the investment in those services, and that's where we're seeing really challenging demand. So just as an example, our inpatient services are consistently full. We do not have any spare beds at the moment. I speak to our community staff, their caseloads are increasing, and I think that's something we all need to be cognizant of. Thank you.
Thank you.
I really appreciate that, Mark, and I think try to reflect some of that in the Chief Exec's report about the gap between capacity and demand. Again, for people who don't know, there's quite strong stipulations around the National Mental Health Investment Standard and what you can invest it in. I think one of the benefits of being a strategic commissioner with more freedom, which is what the government is promising, is that you can work on the basis of the health needs assessment and the current supply issues that you have. So hopefully that would overcome some of that. And it's really good, Mark, to be reminded of all of the additional services that have been put in place over the last few years.
Thank you. Susan?
Yeah, I mean, obviously all this, we have residents front of mind, but also there's a cost, isn't there? And just thinking about what you say there, have we got a business case template for this work? Because if we are preparing strategic commissioning, then we need to invest in things that are going to reduce the demand on that acute end. So have we got any evidence that obviously, probably a bit too early days, but the investment that's been made in the early help side has actually reduced the demand coming through acute? And if it hasn't yet, then we need to perhaps expand that to more people. And so it's having the financials behind it really and understanding the numbers. So when it comes to commissioning, we know how long the payback's going to be and where the investment needs to go for maximum impact. I've not seen that, but the NHS might be working on that business case. I don't know.
Yeah, okay.
So certainly from a mental health support team point of view, nationally, there is an evaluation ongoing. So that's the mental health support team is the support into schools. So there's a national evaluation that's basically trying to do exactly what Susan described, which is, has that had an impact on the number of children who then go on to need, CAMS intervention, etc. I'm not sure if we've seen it yet, but we can try and see if it exists or whether it's still in progress. inevitably within the other elements of kind of early prevention, there'll be certainly pockets in each of our places when we've done bits of that work and we've seen an impact. But what we probably don't have yet is that all pulled together in a way that goes that we demonstrably can know that is the right answer, or that's the right way that will work across all communities. And it kind of links a little bit to Nadra's point as well. We've got to be a little bit careful about inferring that it will work everywhere if it's worked in a couple of places too. But we can certainly see what we've got and bring it back or share it with this committee.
Okay, thank you very much. It's been a really good discussion. I think we bring that item to a close now. So we've got the four recommendations set out as direction of travel, which we've talked about, plus the 2 additional points about the mental health standard and looking at the evidence around social media use in children and advice there. If people are happy with all of that, we're ahead of our timing, but we will take a short break at this point, not least because there's an issue with the live stream which we want to try and sort out. And I'm assuming there might be tea and coffee available, Laura. Yes, there will be. So we'll aim to resume at 5:02, if that's okay with everybody. Thank you very much.
will come up.
Okay, good afternoon. Welcome back, everybody. If we can take our seats. Just as we're starting again, apologies to people trying to watch on the live stream. Apparently, there are a couple of problems, one of which is it's coming up with the names of councillors who normally sit in those seats rather than the people speaking. The second is that the cameras only pick people up if they're standing up. So people may be hearing disembodied voices. Now, could invite you all to stand when you're speaking, but I've got a feeling that might not go down that well. So apologies, we will carry on doing our best. So item 7 is our ambition to increase early diagnosis rates for cancer, and I'm going to invite Jason to introduce this item.
Yes, so good afternoon, everybody. So thank you for inviting me to come and speak to the board this afternoon. So just firstly to introduce myself, my name is Jason Pollock. I'm the Managing Director of the West Yorkshire and Harrogate Cancer Alliance, and we work very collaboratively with all partners across the partnership to help deliver the ICB ambition to increase the early diagnosis rates from cancer. There is a kind of a paper attached to this item, which I know was shared with all the papers at the start. So I'm just going to, if it's okay, make a few of the salient points from the paper. The first thing is to say is that clearly in the national policy context with the 10-year health plan, the expected national cancer plan in February, and indeed the ambition of government to try and improve outcomes for people affected by cancer, a few things are kind of plain and clear. First of all is that cancer is a very significant population health priority right across West Yorkshire. Secondly, it's going to become more of a case in the future because we expect that 1 in 2 people will be affected by cancer at some stage in their lifetimes. And thirdly, with the overarching impact of health inequalities, indeed there's a greater cancer challenge for us to all face to improve the outcomes for people affected by cancer locally. So what we kind of set as an ambition in the current joint forward plan was a commitment to have 1,000 more people have the opportunity for curative cancer treatment by 2024 than was the case in 2018-19. And I'm really pleased to share with the board that indeed that particular outcome has been achieved, and that can be demonstrated through something called the Rapid Cancer Registration Dataset, which is an analysis around what stage is somebody diagnosed with cancer on a level of 1, 2, 3 and 4. So stage 1 is a cancer which is locally defined, indeed hasn't spread any elsewhere, whereas 4 is a cancer which has spread to distant organs or systems in the body. And essentially speaking, stage 1 and 2 cancers are easier to treat, indeed have a higher chance of a curative and a favourable outcome than do cancers at stage 3 and stage 4, although it does vary from patient to patient. So again, really pleased to say that, again, with all the work that's been done locally on early diagnosis by all partners, that 1,382 people more were diagnosed at early stage cancer 1 and 2 within the period of the joint forward plan already, which makes that curative treatment more possible. And again, what we've also seen for the first time in a decade or so is the actual early diagnosis rates increase in West Yorkshire in a way which is statistically significant. There's a number of drivers for that really, one of which is the work which has been done by all partners, so including partners in public health, in screening, in primary care, and colleagues, for example, in RT and the Cancer Alliance, to make the case for and to encourage engagement in the cancer screening programmes, particularly for people with breast, bowel, cervical, and indeed reviewing for the lung cancer screening programme which has been rolled out at the moment. And making the case why actually coming forward for screening is indeed the right choice, supporting people to make an informed choice about screening, and breaking down those barriers and stigmas which have affected people in the past from actually coming forward and taking forward that opportunity, and really being clear about actually why those barriers and stigmas are different in different sections of society and by different groups affected by health inequalities. So that has helped us that kind of progress there has really helped us meet that goal. The lung cancer screening programme, which is currently being rolled out across West Yorkshire, is truly groundbreaking really in terms of what's been achieved. So more than 100 people so far have been diagnosed with cancer through that programme. That's building on the excellent work of the Yorkshire Lung Screening Trial, and indeed actually some of the work we've done in Bradford District and Craven and North Kirklees to make that opportunity available. I'm pleased to share and confirm with the board that indeed the lung cancer screening programme will be commissioned in all residual places in West Yorkshire and Harrogate in 26-27 with a view to complete by the end of the decade. That particular programme, as well as also, if I may share, kind of delivered something which I've rarely seen within my professional career, which is creating an inverse relationship between health inequalities and clinical outcomes. So it's now the case in West Yorkshire that because of that lung cancer screen programme, you're more likely to have a favourable and early diagnosis outcome if you are from the lower decile in terms of health inequalities and the highest. So indeed, it's actually turning around that kind of expectation we have normally in terms of, unfortunately, health inequalities lead to poor outcomes. It's really positive to see. The other points I wanted to kind of flag in this paper as well is that we're doing a lot of work with colleagues in terms of the Core 20+5 programme. And as a Cancer Alliance, and we're a non-statutory body which receives transformation funding to deliver the goals set out in the National Cancer Programme, we're also doing a lot of work across a range of other areas. So not just encourage people to come forward for screening, but also looking at case find initiatives, looking at mechanisms to improve cancer messaging, to improve and break down the stigma and barriers to people coming forward to cancer treatment. We also put in place a number of innovations in the cancer pathway to make that access journey simpler and smoother for people. And we also as well are making sure as well we're learning from partners and adopting innovation locally. So again, we're really proud as a Cancer Alliance to be one of the systems in England which is a major player in the delivering the Small Business Research Initiative or SBRI scheme, making schemes for improving cancer outcomes available locally and first. So the points just to kind of touch on here is that we do also as well, really as a Cancer Alliance, work with all of our partners, try and make sure that we bridge the gap between delivering national policy expectation, translating it locally, and also hearing from partners from across West Yorkshire what really matters to them and making sure that we have a combined offer. I think as a kind of a cancer system at the moment, we are doing a lot of work to make sure this work is being delivered, not just at a system level at West Yorkshire, but also as well with our place-based partners. So indeed, we have an early diagnosis strategy for improving cancer outcomes in each of the constituent 5 places in West Yorkshire. We have invested in a leadership team of management and clinical individuals to help oversee that work with data support and overseeing capacity. And we are also as well are working through the overlay and the relationships with our public health colleagues and others who can actually invest in and support and deliver that work locally. We're also really proud as well to work with our voluntary community and social enterprise partners. And as linked to all this work, and as indeed referred to in the paper, we have a very active programme of innovation grants support indeed our VCSE partners make their contribution to living this system-wide agenda. The other point to describe is where we kind of fit into the new operating model for the NHS. And indeed, as everyone will realise, we're in a time of change. We do recognise that the early diagnosis agenda has a lot to play in terms of the neighbourhood health agenda. So what we're doing as a system as well is we're trying to think about what are the most significant overlays with cancer so far. And we are currently progressing work in terms of how we can think about the impact of frailty for the population that's affected by cancer, and also what we can do at the latter end of the pathway as well to think about the impacts of people affected by cancer who are having repeat admissions, and indeed we can improve their experiences up to and including the end of life. So again, we are working on that kind of neighbourhood health overlay as part of our strategy development work for this year. Going forward, I think from a policy perspective, I'm pleased to confirm that last week that Cancer Alliances were confirmed to have further funding for the next 3 years as part of the government's comprehensive spending review. We're expecting a national cancer plan in February as described, which will set out a clear mandate of expectations for us in terms of early diagnosis and other themes. We progress this agenda around early diagnosis alongside all the other things which are important to people, including the population of people who are living with and beyond a cancer diagnosis, those people who need to get access to treatment sooner, and indeed those people who indeed are looking to benefit from increased access to research and clinical trials. So this is part of a positive agenda. It's where we're making good progress in the system, but I'd also recognise we've got a long way further to go. So our current rates for the diagnosis are around 56%. They have increased by about 1.5 to 2 percentage points in year, and we're seeing a similar trend in the current year. But again, there's a long way further to go to deliver those outcomes we want to see for people affected by cancer locally. And I'd like to pause there to take any questions from the floor.
Thank you very much, and thank you for a very comprehensive report. Questions? Yes, Rebecca.
There we go. Hi. Thank you. My name is Rebecca Todd and I'm the Independent Chair of Leeds Committee of the Integrated Care Board at West Yorkshire. So when you've talked there about cancer diagnosis, which is brilliant, and the lung cancer vans, I'm assuming the ones that were in supermarket car parks in particular areas, they've really used data from public health and neighbourhoods really well to kind of focus that, and people were invited to it from lists who were kind of identified. So it was making me think about the population health management approach and the future of the sort of integrated care board work around that, neighbourhoods, but then at West Yorkshire as well. And I just wondered if there was a sort of idea about how we can do that going forward, and if there was plans or something sketched out. Thank you.
So I think what we have done is, particularly through the perspective of, say, lung cancer screening, is we have looked at the likely eligible population for lung cancer screening right across West Yorkshire. So we've done that by looking at current and historic smoking status to identify, when we do get round to expanding that programme across West Yorkshire, what's the eligible population, how do we engage that population, how do we use insight data relative to that local population. That's very much a partnership effort between our place-based colleagues and indeed work we're doing at system level. I think there are a number of things which we have kind of learnt there, which do apply to other areas as well. So, for example, it's referred to in the paper, we're doing quite a groundbreaking expansion of liver cancer screen surveillance for people who've been affected by hepatitis C. To basically to look at case finding there. And we're also looking within the lung cancer screening community, the people who are eligible for that programme, to trial a scheme to look at potential kidney cancers amongst the same eligibility cohort. All these things kind of are coming from quite a holistic approach in terms of how we get the data to look at that. So, for example, it's working with population health colleagues. It's also working through with academic partners. It's also working through some of the intelligence we have from our other cancer alliances and applying that locally. And it's also looking through what we can do in terms of working with clinical champions from provider trusts. Again, it's very much a convening effort that we put forward. I would agree that I think it's absolutely key in the operating model going forward that we retain that focus and partnership working and working together. And I think that hopefully the kind of cancer alliances and that will be the glue which kind of holds that system together.
Thank you. Helen?
Yeah, thank you very much. Thank you for your report. I was surprised to see no reference to community diagnostic centres within the report, and I guess I have a couple of questions in relation to those. One is, are we gathering any data and information from those in terms of earlier diagnosis? And if we're not, have we got plans to do so? And I think the second was, given the physical location of our CDCs, or many of them within sort of, more sort of public areas, I just wonder whether or not we're incorporating within sort of the areas where they are some form of more awareness campaign, advertising, and utilising their positions really in terms of earlier diagnosis.
Yes, I think it's the community diagnostic centres. So it's actually the profile quite heavily in some of our commission intentions in principle for next year. I think it's fair to say that that from a policy perspective, they've been guided by the opportunities to improve access and operational performance, as well as actually achieve some of that early diagnosis. So from a national policy perspective, they feature more heavily in widening access and operational performance, but they do also, as you're right to say, have a key role to indeed improve early access to diagnostics and therefore improve some of the objectives around early diagnosis of cancer. I think that what we are doing is we are collecting data around the utilisation of CDCs. We are collecting data in terms of the patient perception interaction with those facilities and how they compare with facilities in the past. Broadly speaking, that's positive. We are also looking about how we are utilising the CDC facilities within the West Yorkshire and Harrogate system compared to our colleagues nationally, and indeed a number of areas we are expanding the CDC offer beyond the original national template, which is positive to see. I think the broader point is to say that as we expand upon the need to diagnose cancers earlier, there will be both partnership population health elements to that, but there will also be a necessary extension of access to diagnostics. Because I think it's recognised that even with all the positive investments in CDCs over the previous years, our access to some of the frontline diagnostic kits per capita is lower than some of our competitors nationally. Again, that's one of the themes which I think was picked out in Aridazi's report. So again, I agree with that. There's both the investment in the CDCs themselves and indeed the integration of the policy 22.
Jen?
Thank you. Just building on the point that Rebecca raised actually about the kind of the balance and thinking about earlier diagnosis. I think it's really important to have that focus, but we shouldn't lose focus both on the ultimate outcomes that we see, because obviously we want those earlier diagnoses to lead to more positive end outcomes. So it's kind of keeping that in mind, because when we're thinking about any screening programme, we know that does harm and we want it to do net good. And so keeping that in our minds, I think, when we're thinking about some of those population health, sort of once we get into risk stratification, it gets bordering onto screening, which we just need to make sure we're kind of clear in the definitions there and the importance of having screening programmes that do lead to that net gain. And also it was really good to see in the report that we're not losing sight of those real preventative opportunities like smoking cessation and things like that, that ultimately have that, you know, big population health benefit if we can kind of get those. So I think just making sure that I really welcome the kind of improvements that you're seeing in early diagnosis, but making sure we're keeping that holistic view of the totality of outcomes at different ends of the spectrum there. Thanks.
Yeah, I'd absolutely agree with those points, Jen. I think just to reassure colleagues, in terms of the work we're doing on the screening programmes, both current national screening programmes and those which are being reviewed for in terms of expanded access, they're all based on recommendations of the National Screening Committee, so they all stem from NICE guidance. Where we are extending it into forms of case finding, that is also as well reflecting kind of national guidance and indeed, so for example, one of the pieces of work which we've been working with some colleagues on is to expand access to PSA testing amongst black men, because we do realise again that there is a higher instance for some black men affected by prostate cancer than there is the general population. So again, there's a case in need there which we respond to. Also as well to say is that we are as well following the guidance from the National Screening Committee in terms of where they're going to go on potential future screening programmes. So for example, we are waiting for updated evidence and opinion from the NSC about the role for potential national prostate cancer screening programme, and indeed we'll respond to that as an alliance based on what comes forward. I also agree about the points about prevention, and both from a primary prevention point of view and a secondary prevention point of view. I think that, for example, going back to the lung cancer screening programme, that also has kind of teachable moments and indeed very brief interventions that's embedded as part of the delivery offer to that programme. So again, if somebody does come forward for lung cancer screening and they want to use it as an opportunity to consider a smoking cessation measure, again, that's supported as part of that programme. There's onward referral. I think the other points to just kind of describe as well is that, again, we are trying to make sure as well that we're reflecting the whole range of the risk factors which influence cancer diagnosis from the International Cancer Benchmarking Partnership. So again, where we are as well trying to make sure there's greater prominence in the National Cancer Strategy coming forward is for new areas around excess cancer incidence. So for example, we're pushing the case that air quality is recognised directly in the National Cancer Plan as indeed something which impacts on avoidable cancer incidence, because again, as we know from Cancer Research UK, cancer incidence going up, but up to 4 in 10 of those cases are avoidable through changes to environmental factors or indeed personal behaviour. So again, I think you're absolutely right. It's about diagnosing earlier, but looking at the root causes and indeed supporting people to take action at primary and secondary levels.
Thank you. Liz?
Thanks, Jason. A really positive report and great to hear about all the changes that you're making. And I was very impressed in the paper where you talk about supporting best treatment sooner through innovation and Small Business Research Initiative. You're involved in that, and 45 projects with a Small Business Research Initiative to test out what might work for residents. And I'd just be really interested to know how you evaluate that. So you're running all these streams to support better treatment. How do you decide what's going to work, what's not working, and how do you then take that forward or not, as the case may be?
Yeah, so I think so some of that is within our gift as a kind of a local system. Some of that we are kind of reliant on sharing that information with colleagues nationally to determine whether or not those programmes can scale and have greater reach. What we do with respect to all of the kind of the innovations which we pilot and support locally is we set kind of objective criteria at the start. So for example, what are we trying to see from this innovation? what we're trying to achieve for patients, but we also accept a level of risk that sometimes those projects will fail. And indeed, actually, the right answer to that is we don't proceed with something. So it's right to say that many will, but sometimes we take some really clear learning that something started in good faith with a view to achieve some really positive outcomes, sometimes won't deliver what we intended. So the way we evaluate those is we often embed the evaluation, funding and support into the package around how we do it. So there are a few ways we do that. Sometimes we work with academic partners to help us do evaluation. Sometimes we can collect data locally as a cancer system and do work with other colleagues. And sometimes we use our network of other cancer alliances to help us get that independent view about whether or not with something we've tried locally is delivering for people on the ground. And so it's a mixture of those approaches for elevation, really.
Yeah, thank you. It's really impressive. Thank you. Thanks.
Thank you. Mark?
Thank you. And I'd just like to link this report together with Rob's earlier report and some of the conversations on health inequalities. And Rob's earlier report had some points, some helpful points about the annual leader report. That's the annual report of lives and deaths of people with a learning disability and autistic people. And we know that one of the primary reasons people have suffer an avoidable death with a learning disability is cancer. And I guess it's just really a plea that I guess we can, I know there's a lot of good work taking place in all organisations, I guess, to support people with a learning disability. And I guess it's just a plea that I think from a cancer perspective as well, we do all that we can in partnership to ensure that we actually have effective screening and opportunities for people to be diagnosed early.
Yeah, I'd absolutely agree wholeheartedly with that. I'm not sure if it's actually referred to directly in the report, but we have actually done a specific piece of work to improve uptake of the bowel cancer screening campaign and FIT testing. So that's fecal immunochemical testing. It's kind of looking for bits of blood in the stool. And we've done that specifically through the lens of a co-produced outcome with people affected by a learning disability. And some of our screening campaigns are specifically co-designed with people affected by a learning disability to look at what are the barriers caused by either the way in which we are phrasing things, our written communication, the way in which we are expecting people to follow kind of instructions which require a level of dexterity or indeed understanding, and indeed what we can do to actually offer alternatives to one size fits all. So again, a lot of work been done through the lens of bowel there. We've also done a similar piece of work in cervical, but absolutely agree is if you look at the outcomes for people affected by cancer who have a learning disability, they are worse. Sadly, they're worse across the board, and indeed it's really key that when we're doing this piece of work and this strategy going forward that we are keeping our minds not just the general population need, but also the population affected by learning disability as well.
Fatima.
Could not agree more with that previous comment. I think if we get it right for people with learning disabilities, we get it right for a lot more other communities as well. Just a couple of questions, Jason. One is about sort of the future commissioning intentions, and then one is about general access and how the combined authority can help. So one of the things that is really exciting about strategic commissioning is that we can use a health needs assessment to inform how we strategically commission in each place. I suppose my question is, how do we harness that as an opportunity to improve the work you've already started on improving access and outcomes for people from different protected groups? And then my second one is some of the work that I do with Tracy enables me to meet lots of people in different communities. And some of the feedback I've had, particularly from people with access challenges, is that travelling to tertiary sites for treatment can be really difficult using public transport. Obviously, buses are now back in public control, and there's a really great opportunity for us to really, I think, revolutionise actually how people access care. Can we have a convo outside about how we can get you involved in those conversations and really support that?
Yes, absolutely. So the second point is we also receive similar feedback as an alliance through some of our patient engagement work that the burden of impact on travel is really significant. So I think it's worth reflecting that for some people going through cancer treatment, they will often go every day for multiple weeks. For some people, they will go whilst immunocompromised over a period of many months. And increasingly, people will have multiple rounds of treatment over many years because cancer becomes increasingly a chronic condition. So the burden and impact of travel is not linked to that individual journey. It's a wider determinant of the overall experience of accessing care. We do have the particular conundrums working through in terms of, for example, things such as non-emergency patient transport access, which again is something which is key and we hear from patient partners. We have tried a number of innovations in space, but again, we want to be a little bit more successful. So we have tried something with colleagues in Bradford around making bus tickets available for people at no cost, where that's a barrier. And we have also looked at opportunities as well around dispensated car parking for those people who do actually have access to a car. I do think there's more we can do in that space, because I do agree, ultimately, if we're asking somebody to trek across West Yorkshire in the middle of winter, and indeed not particularly a convenient hour, that's difficult not just for that person, but that person's social family networks, the people around them, and indeed actually the burden of that travel can be significant. So I absolutely agree on that. I'd love to pick that up outside. On the wider point about strategic commissioning, again, I absolutely agree. I think that the key opportunity really is, again, going back to the Cancer Alliance as a kind of a convener in the system being there as a bit of glue, is we've got an access to an awful lot of data, information, insight, intelligence, not just locally, but also from our peers nationally, around what works and why. So I think it's around us working really in partnership together and say, this is what we've seen's worked elsewhere, or this is what's worked in West Yorkshire. How can we spread it and how can we learn? And how can we make sure that indeed when we're doing our strategic commission intentions, they're guided by that rich local intelligence around what's going to make a difference to people affected by cancer? Because I absolutely agree, it's a huge opportunity. We must seize the opportunity.
Thank you. Sylvia?
Thank you, Chair. So just following on from what's been said then, and as a councillor from Calderdale, I think, yes, the issue of travelling to and from hospitals is a very live one. So I hope you take account of that when you're having that discussion. Even down to simple things that could make life easier by thinking about the timing of appointments. So saying to somebody in Todmorden that they have to get to a hospital for 7 o'clock and then sit around for hours is just so thoughtless. So I'd certainly hope that maybe moves can be made to stop that sort of thing happening. I understand, I know there's all sorts of other considerations. And the other thing I wanted to say about inequalities is I think organisations like ourselves all have a role to play. So Calderdale recognise that men are particularly bad at thinking about cancer, so they can have unequal outcomes, and also that economic factors have a bearing as well. So the lower down the scale you are, the less likely you perhaps are to seek help. So we had a men's wellness day where we had a talk for men who of course were mostly from the outdoor services, so mostly not particularly well paid, not digitally enabled within the council. And we had a talk for them called Bits, Boobs and Poo about screening, why it matters, when it's effective, how you talk about cancer. And at the end of that, the men at that talk voted to say that, yes, they were far more now inclined to talk about cancer, to act upon symptoms than they had been at the start of it. And so all of us as employers can do simple things like that, I think, even though we might work in organisations where we think that this would be obvious to the people that we work with. But the other interesting thing that arose from that is it was so successful, they repeated it at a general wellbeing event where men and women were present, and we ended up with a complaint or two about the language used. So things just have to be tailored to the people that you're trying to attract, otherwise you're just going to lose it.
Yeah, I think there's a few points there. I think on the bit about breaking down barriers, improving awareness and creating propensity for people to engage in health behaviours we want to see, you're right. What we often find is it's not just what the message is, but who delivers it. And that's why with some of the work we do, we work deliberately with a number of voluntary community and social enterprise organisations, or indeed patient-led organisations. It's not the formal NHS trying to have those messages all the time. Indeed, it's messages that we would share and offer, but when they're being delivered by a community advocate, they make more impact and meaning. I think there's a number of things you said there. So there's another element of kind of national policy which we're trying to get traction on for some work in West Yorkshire, which is around creating cancer-positive employment practices. So it's recognising, again, there are some simple things which employers can do to be supportive of their employees generally. So if one of them, for example, is to give them paid time off work to go to a cancer screening appointment. It's to recognise if somebody has been affected by cancer and comes back into the workplace, they're not just cured. Indeed, there will be an impact on their general health and well-being, and indeed reflect that in the way in which they kind of treat and incorporate that person back into work. And also as well to recognise the fact that indeed that, again, for many people, cancer, as I said, will be a chronic condition. So recognise the fact is that some of the things which you might experience in other long-term conditions will also affect people affected by cancer. Indeed many people affected by cancer also have other long-term conditions too. So again, all those points. On the wider bit about transport as well, I do appreciate and know that's a particular issue from a Calderdale context too, absolutely agree. We've done some interesting work with the Halifax Opportunities Trust as well locally on some of these points and areas. So breaking down barriers, and also in Calderdale we have a very extensive community model of support really. So really looking at the barriers to the most vulnerable groups in society, and looking at not just the cancer, but also the needs of the person affected by cancer. So we do things called holistic needs assessments, and essentially the whole range of needs which somebody will have based around, and for example, their impacts on their employment, their finances, their social health and mental well-being, psychological well-being, the impact on families. And so again, those assessments take place to make sure we give that right offer of holistic support to people. But I do agree with what you said. It's again, choice is important, advocacy is important, treating the whole person is important. And the other thing we do is try and listen to patient feedback as well, so from things like the National Cancer Patient Experience Service. So each year we get a very good comparative data set around, for example, what do people from Calderdale experience in their cancer care and services compared to nationally, and we make sure that's followed up in local action plans. So one of the areas we've been looking at this year across the Alliance has actually been the impact of fatigue. So one thing we've really heard from people is that when they're going through cancer treatment, they're affected significantly by fatigue. Sometimes they are not describing how to follow up and act on those messages. So again, we put in place a range of support programs, information and signposting around what people can come forward with when they experience those symptoms. So hopefully that's helpful, but I agree with all the points you've made.
Thank you very much. It's an incredibly comprehensive report and an awful lot in there as well. I've got Susan and then I'll bring Rob in. Yeah.
Thank you. Sorry, I missed a little bit. It's had to go out because actually somebody, I've just been sorting out a death. Somebody died at 69, and unfortunately in Bradford, I get a lot of that. People dying actually. 69 is obviously a retired person, but it's still not to an age where some of these schemes kick in. So when you've got health inequalities in a place, is the age the right time to intervene, or should inequalities in certain communities where people die 10 years earlier mean that actually in some communities you probably need to start screening earlier, or is that not a thing? I don't know. Is it too early? I don't know about cancer diagnosis.
So again, with the general point, we unfortunately do see the significant differences in life expectancy from the most affluent to the least affluent populations, which impact on their health conditions. For example, something like the lung cancer screening programme is eligible from the mid-50s. And so it's 55 through 74, I believe. And we've also seen, for example, the expansion of the bowel cancer screening programme down to age of 50. So you're right to say that, that indeed, that the experience of people having healthy life is sadly not as significant in our least affluent communities as it is in our most affluent communities. Indeed, our overall rates of life expectancy are not the same across West Yorkshire. But I would say that most of the screening programmes are following the National Guidance to the Evidence, and that's to then try and direct on where you are likely to pick up a significant enough instance of disease to justify the potential harm for the screening episode, going back to Jen's point earlier. So again, if you over-screen and you over-intervene, you can also cause harm. So it's a balance. But I think in most areas of the cancer programme, the screen offers are available at an age which is responsive to the needs of populations affected by health inequality, and they're often being offered at an earlier stage of life.
Yeah, thanks, Jason, for the report and for the contribution today. It's good to see the impact that the work has had through the Cancer Alliance and the Integrated Care Board and the Integrated Care System. So those 100 people diagnosed, for example, and the over 1,000 that you talked about in one of the other programmes. And the disproportionate, in a positive sense, take up of some of the programmes. It's really good to see. I think the thing that I'd want to just remind everybody, in reminding myself as much as anything else, is when we talk about cancer, people often think about the acute end of treatment, but what we've just heard from Jason is it's from primary prevention through to survivorship or end of life, and all points in between. And all of the interventions that you've talked about, I think, have been partnership interventions, haven't they? There's been a significant amount of work to be done by trusted voices in communities, by the VCSE, by people themselves, and peer support. So having that kind of system approach, and I thought, Becky Childwood's points about population health management and insights really useful. We're about to go through a period where this will continue to be a significant priority for the country and for the NHS and the wider system. We've got a national cancer plan coming out in February, I think you said. We will have to deal with the fact that that's after we've signed off our 2-year plans. I understand it's going to be the first 2 of the 3-year plans. I know that councils will have been thinking about their budget setting and everything else by then too. So that's slightly difficult. And one of the things that isn't clear yet is what the changes to NHS England structure mean for the way that delivery happens. So we've had a very strong central direction around cancer and priorities through cancer alliances and with the support of ICBs into delivery. NHS England, as everybody's seen, is going through its own changes and its own voluntary redundancies, and is being absorbed into the Department of Health over the next year and a half. I think I'm just putting on record, I think, that we will want to see this work persist in the best way possible to continue to target the communities furthest away from care, people with learning disability, people in poorer populations, men who had come forward too late, as Councillor Dacre was describing. And therefore, we're going to have to take that into account in the organisational change processes. So screening programmes will come to ICBs in 2027, I think is the plan. The wider public health interventions with councils will continue, won't they, around smoking cessation, alcohol, obesity, weight management, etc. And then the treatment options and some of the other diagnostics will be in the service. It's one of the reasons why we wanted to make sure that in any structures that we're looking at, some of the outstanding issues around cancer are addressed before we go to full consultation. So just to explain that to people. And I think we should come back when we get the National Cancer Strategy just to see, have we got the right delivery vehicles now then to get this to work? And as a strategic commissioner, as a partnership, do we have the space where we're thinking about the population and the interventions, as well as what the national directions will be? Because the blend of those two things has got to be right.
Yeah, I'd absolutely agree with all those points, Rob, and thank you for kind of drawing that together. I think just my simple observation would be is that even if the structures change around us, the need doesn't. And I think it's incumbent upon us all, because we've all got an investment in this agenda to improve the outcomes for people affected by cancer right through the whole pathway. We've got a responsibility to make sure that kind of work persists. And indeed, we will play our part as a Cancer Alliance in that, but it's going to be a part with other partners all across this room. I think that's really come out in the conversation. Points that we'll just raise about the National Cancer Plan, yes, it will be in February. I'd agree it is slightly unhelpful. The fact is we have an entirely separate cancer planning process to everything else. So again, we need to make sure again that work comes together, and we certainly would be very happy to come back once we've got that narrative together to make sure we've got the delivery vehicles in place you described, Rob.
There's just something about if we've spent all the money or allocated all the money or thought about the use of all the money, any adjustments we have to make subsequently will be very difficult.
Thank you very much. I'm not seeing any further comments. So thank you very much for that report, Jason. I'm happy to endorse the recommendations. So thank you, everybody. That brings us to the end of the meeting. I've not been notified of any other business. I just ask people to note that the work plan's been circulated. And Laura, can you remind me what we've agreed about the date of the next meeting? Because I've forgotten. Yeah, so the next meeting is different from the date it was originally said. It will be on the 3rd of February, but we'll be sending out invites for that. Thank you very much, everybody. Thank you for your contributions.